Good morning, class. So for the part 2 of disorders of bone and mineral metabolism, we are going to discuss first hypocalcemic disorder. So in the previous lecture, we discussed disorders that cause hypercalcemia. So in this case, we'll discuss the other end of the spectrum. So what are the signs and symptoms of hypocalcemia? So just remember the mnemonics convulsion cats. Cats go numb. Convulsions, arrhythmias, tetany, spasms and stridors. So and numbness in the finger. So usually, if you go into the clinics and you see a patient after a thyroidectomy, that's where we usually observe patients with hypocalcemia, especially after a thyroidectomy when the blood supply to the parathyroid gland is disturbed. Some patients undergo transient hypoparathyroidism that manifests as hypocalcemia. So as a clerk or an intern or a surgery or ENT resident, you have to check for this post-operatively. So what are the things that we check? We check for Bostic signs. You tap the you tap the temporal area and look for twitching of the face, um, signaling muscle irritability. We also look for this one, the trousseau sign. So that's the characteristic appearance of a trousseau sign. It's also a form of a sign of hypocalcemia. And of course, you have your seizures, tetanies, and arrhythmias, especially in severe cases of hypocalcemia. Sometimes, but the most common manifestation is just simple numbness in the fingers, as well as in the peri-oral area as well. So how do we classify disorders causing hypocalcemia? You just have to remember 3 classes. So you have PTH absent. So if, of course, you don't have PTH, this can cause hypocalcemia. And as I discussed earlier, the most common cause of this is an acquired hypoparathyroidism, usually post-surgical after a thyroidectomy. So after a thyroidectomy, usually this is transient, but in worst cases when the surgeon is unable to avoid taking out 1 or 2 of the parathyroids, patients can have permanent hypoparathyroidism that usually lasts more than 6 months from the time of operation. So there are also cases where you have ineffective PTH, just as in CKD, the lack of active vitamin D. No, so in chronic CKD, you cannot activate your 25-hydroxycholecalciferol into the active form of vitamin D. So active vitamin D lacking, lack of dietary intake or sunlight, defective metabolism. Some anticonvulsant drugs can also cause vitamin D deficiencies, and so on and so forth. No? PTH is overwhelmed usually if there's increased load of your phosphate in these scenarios, but these are not very, very common. So these ones are the ones that we see more often in the clinics. So how do we treat patients with hypocalcemia? Most of the cases are usually mild. But if the patient develops acute hypocalcemia, this is an emergency because patients can go into arrhythmias, to fatal arrhythmias or seizures. So you can give 100 milligrams of elemental calcium over 10 to 20 minutes. So this is usually in the form of calcium gluconate. Calcium gluconate is the IV form um, of your calcium, and coupled with the magnesium, over 24 hours. And of course, you have to treat the underlying disorder. Calcium supplementation on top of the IV is important, but if the hypocalcemia is only mild to moderate, you can actually do away with the IV and just give oral calcium supplementation. So calcium carbonate is the least expensive. So the most common form of this would be your Calcrate, your Calvin, even your Tums, no? They your Calcichews also is calcium carbonate. So this is the least expensive, but we need to be able to acidify it for efficient absorption. This is about 60%, if I'm not mistaken, 60% elemental calcium. No? This can be given in divided doses. Usually calcium carbonate is in the form of calcium carbonate 500 milligrams or calcium carbonate 600 milligrams plus vitamin D. So a calcium carbonate that is 600 milligrams times zero point 0.6 would be, sorry, zero point 0.4, sorry, 40%. So calcium carbonate has 40% elemental calcium. So 600 times 40% would be 600 times 40% would be about 240 milligrams of elemental calcium. Plus, you have to include calcitriol also because since you do not have PTH, you are unable to activate the cholecalciferol or your vitamin D with the active vitamin D. So what you need is already an activated vitamin D, which is in the form of your calcitriol. So this is usually in the dose of 0.25 milligram per tablet. So you can give as high as 2 milligrams per day or even higher in severe cases. So a dreaded complication of parathyroid surgery from um, primary or hyperparathyroidism is called your hungry bone syndrome because of in patients who are very used to having high levels of PTH, just in primary hyperparathyroidism. If you take out the parathyroid adenoma causing the hyperparathyroidism, there is an acute reversal. Because of the acute reversal or the sudden withdrawal of your PTH from the circulation, there is an imbalance between the osteoblast-mediated bone formation and osteoclast-mediated bone desorption. So there is higher bone deposition of both calcium and phosphorus, causing severe depletion of your calcium in the blood. No? So your severe hypocalcemia. So from the terms of the bones are very hungry for calcium because of the chronic severe bone resorption. So since from the high levels of PTH. So if there is a withdrawal of the PTH, the bone starts to get all the calcium it can get from the circulation, causing severe hypocalcemia. So this is dangerous, if it becomes severe. Usually patients would have um, severe numbness, tetany, carpopedal spasms. No? In very severe cases, they can go into fatal arrhythmias. So this usually, if you treat this adequately, usually goes into nadir in 2 to 4 days. You can also have hypophosphatemia, so you also have to replace the phosphate levels of the patient. And as I mentioned earlier, this is caused by a decrease in bone resorption and an increase in bone formation because of the very, very hungry bones. Okay, so we'll just describe briefly bone structure and metabolism. So your bone is a reservoir of what are the functions of your bone? It is provides strength and density. It is suitable for both mobility and protection. It's also an important reservoir for your minerals such as your calcium, magnesium, phosphorus, and even other electrolytes, your sodium and other ions. And lastly, it's also a niche for your hematopoietic cell proliferation and differentiation. So this is the distribution scheme of minerals in the bone matrix. So it's a combination of collagen molecules as well as crystal layers in between. provides that provides strength that will withstand mechanical stress. Okay, so remember how your bone resorption works. So I think we've discussed this in the previous slides, and just remember how your hormones affect bone resorption. So this one is the hormonal control of bone resorption. So what's important to remember here is what are the things that promote bone resorption and what are the things that promote bone formation or your anabolic factors. In the factors that promote bone resorption, it's important to remember your vitamin D and your PTH, your prolactin and your corticosteroids, as well as acute phase reactants or interleukins. In their anabolic factors, it's important to remember estrogen. So that's why patients who go into menopause, no, their estrogen gets depleted, their capacity to form bones or the anabolic capacity of their bones um, is reduced. That's why patients who are postmenopausal are at high risk to develop osteoporosis. So on that note, no, we'll now have to discuss the clinical correlation of bone metabolism. No? A very common condition that is usually under-recognized is your osteoporosis. No? So you have a healthy bone that turns into your weak bone or your osteoporotic bone. So what is osteoporosis? Osteoporosis is a condition where you have a low bone mass as well as microarchitectural deterioration of bone tissue. And because of this, there is enhanced bone fragility resulting in increased susceptibility to fractures. And the most susceptible will be your hip, your back, your vertebra, especially your lumbar vertebra, as well as your wrist, especially in patients with hyperparathyroidism. So how do we diagnose osteoporosis? So the diagnostic test that we request is a bone mineral densitometry or your DEXA scan. So this is the um, the gold standard in diagnosing osteoporosis. So if you have a bone mineral density value with a T-score of 1 and above, no, uh, yeah, -1 and above, then you have healthy bones. We have osteopenia. If you have a BMD T-score value between -1 and -2.5, and you're considered to have osteoporosis if your BMD is less than 2.5 and below. If your BMD value is at least -2.5 and the presence of fracture will also clinch the diagnosis of osteoporosis. If the patient is premenopausal, then you use the Z-score. If the patient is postmenopausal, you use the T-score. So what is an osteoporotic fracture? A fracture that occurs spontaneously or with minor trauma such as fall from a standing height or fall from a sitting height. So for example, the patient is just walking in the mall and suddenly uh, slips on maybe water on the floor and falls from a standing height, developing a fracture, then that's an osteoporotic fracture, or what we call a fragility fracture. A fall from a sitting height as well is also cause of fragility fracture. But for example, even if it's an elderly and the elderly gets hit uh, by a jeepney, you know, it may or may not be considered as a fragility fracture because it's a high impact trauma. Okay, but of course, because of the age, you have to consider that patient having osteoporotic fracture. What are the factors leading to fracture? Of course, number one would be the age, onset of menopause, so patients who have early menopause, probably patients who have developed hypogonadism, or patients who have surgical menopause at an early age that leads them to early depletion of the estrogen, leading to increase in bone loss. And other risk factors, what are other risk factors we will discuss in the next couple of slides. This is some of the examples would be chronic steroid use, what else? Lack of vitamin D, etc. We'll see that in the next couple of slides. So all these factors can lead to increased bone loss. And if you are not able to achieve your peak bone mass because of whatever reason like diet or lifestyle, this can both contribute to low bone density. And the low bone density increases your propensity to develop fracture. No? And usually this is aggravated by an increased propensity to fall. For example, in the elderly, sometimes they are at high risk for falls. Patients who are on sedating drugs, they can also have an increased propensity to fall. And patients with poor bone quality, such as patients who have metabolic bone disorders, they all can increase the risk of a patient developing osteoporotic fractures. So who are at risk for osteoporotic fractures? So these are the clinical risk factors: age, previous fracture history. So the motto of your FSL or your fracture years and service is the first fracture should always be the last. If the patient has an osteoporotic fracture and develops another fracture, that's almost a cardinal sin, no, of a cardinal sin for patients. Not a cardinal sin, but it would be sad if a patient already had an osteoporotic fracture and we are unable to do anything to prevent the second fracture because we've already identified the patient as a patient having high risk for another osteoporotic fracture. Another risk factor would be parental history of fracture, um, current cigarette smoking, alcohol intake, on corticosteroid for more than 3 months. So this is the most common cause of drug-induced osteoporosis or corticosteroids. In the Philippines, a lot of our patients, one common thing that I ask my patients is, do they have arthritis? And if they have arthritis, are they taking as needed steroids? No, that is usually prescribed by their kapitbahay, but for them. Low BMI, patients who are thin frame, postmenopausal women. So this is, I think, one of the few conditions where obesity is protective. No? Obesity is protective for osteoporosis. And other medical conditions leading to secondary osteoporosis. We had a case before where the patient had an acute had a chronic pancreatitis, and because of the chronic pancreatitis, the patient was unable to absorb vitamin D because vitamin D is a fat-soluble vitamin, and because of the severe vitamin D deficiency, the patient developed secondary osteoporosis. Yeah. But remember, the age and the prior fracture history are the strongest predictors of fracture risk. So what are some medical conditions leading to secondary osteoporosis? Premature menopause, rheumatoid arthritis, hypogonadism, including hypogonadism, inadequately treated hyperthyroidism because of the um, high bone turnover, because remember, in hyperthyroidism, everything is all the metabolic processes are at increased rates. Hyperparathyroidism, of course, prolactinoma causing hypogonadism, malabsorption, IBD, COPD, and anorexia nervosa. So who are the people who needs to undergo bone mineral densitometry? So I usually ask this in the exam. So you need to remember this. So you know who to screen when you're a general practitioner, an internal medicine physician, or a family physician. You should be able to identify who to test for bone mineral densitometry. So remember, this will be in the exam. So you should consider testing for bone mineral densitometry in the following individuals. Women age 65 and older. For men, the cutoff of age is 70. So women 65, men 70. In younger postmenopausal women, 50 to 69 if there are clinical risk factors for fracture, we mentioned earlier. Adults who have a fracture after age 50, adults with a condition or taking chronic corticosteroids like those who have history of SLE or asthma, who are taking oral drugs, drugs that are associated with low bone mass or increased bone loss. So remember this, okay? So testing patients for bone mineral densitometry doesn't have to rest on the orthopedic surgeon or on the rheumatologist or on the endocrinologist. It's actually in the hands of generalist physicians. So remember how to diagnose. So we measure bone mineral densitometry. And again, this is the criteria. So just look at the T-score for postmenopausal women and Z-score for premenopausal women. How do we determine the probability of having osteoporotic fracture? So we have two tools that we can use. The most common and the most popular one is your FRAX tool. And in Asians, we have your OSTA, your osteoporosis screening tool for patients. So I'll just show you. So you just go to the FRAX website, and this is usually a country-specific fracture risk assessment tool. So you just enter everything here, and it will give you the 10-year probability of fracture in person. Another tool, if you don't have the BMD score of the patient, so is the OSTA. You just plug this in. You are living in a place where you don't have a DEXA machine. So as you can see from the OSTA, it's very obvious that in the elderly, they're already identified as high risk. But also take a look at the weight and the height in the BMI. So those who are those who have low BMI also have an increased risk. So if the patient is already in an advanced age and has a low BMI as well, they are at a very high risk for developing osteoporosis. No? And all the more you will have to push the patient to undergo some testing. So what are the ways in order to prevent patients from getting osteoporosis, or if they're already diagnosed with osteoporosis, these are the things that can help them prevent the worsening of their osteoporosis. No? Avoid too much alcohol, or ABCDEF. Avoid too much alcohol, break the smoking habit, make sure you have adequate calcium intake, make sure the vitamin D levels are also adequate exercise, and of course, fall prevention, especially in the elderly. So, what are the other non-pharmacologic aspects? So, you can increase your calcium intake through food, but if not, you might need to do some calcium tablets as well. But and vitamin D also. No? So remember that women over age 50 needs a higher vitamin D requirement, no? Compared to premenopausal women. So, but take note that calcium and vitamin D should not be used as the sole treatment of osteoporosis. Some patients will just tell me, Doc, can I just take calcium tablets instead of taking the expensive bisphosphonates? I say no because it's not enough. No? Another important non-pharmacologic aspect in the treatment of osteoporosis would be making sure you have adequate protein so that you don't develop sarcopenia. And sarcopenia is also a risk factor to develop fall and osteoporosis as well. Food, caffeine is also an important factor. Remember this, the adequate calcium intake. So for most people, men and women, you just need 1,000 milligrams of calcium per day. But in men and women 51 and older, you need at least 1,200 milligrams. In a tablet of caltrate, you will have 600 milligrams of calcium. So you need two tablets, no, when you become 50 years old and above. But of course, you also have to take into consideration other sources of calcium, such as in your food or in your milk. No? Okay, so who to treat? So if you have a patient that is clinical diagnosed with osteoporosis, let's say the T-score is less than negative 2.5, with or without a hip or spine fracture, then you treat. If the patient is in the osteopenia range, the T-score is between -1 and -2.5, but the 10-year risk of fracture based on FRAX is more than 2% for hip fracture or more than 20% for a major osteoporotic fracture, then you treat. In the absence of a DEXA scan, you just input it in FRAX or look at the OSTA high-risk category. But you have to individualize also the treatment decision. So share the decision with the patient. Okay. So how do we treat? So we have a lot of treatment options. So I usually discuss this one by one with my patient, whatever depending on what they value. If they value side effects, if they value the cost of treatment. So all of these factors will come into play when you prescribe patients with treatment. So the most common drug that we give is your bisphosphonate. So you can choose from alendronate, it's a tablet taken once a week. Lisodronate, once a week also. Ibandronate, once a month. Zoledronic acid. This is an IV infusion, usually given once a year. Usually we give alendronate for a minimum of 5 years and then reassess. If the patient is still high risk for fracture, then we continue. If the patient is no longer at high risk for fracture, the bone mineral density has improved, then we can actually stop treatment with alendronate after 5 years. If you give zoledronic acid, you can give it for 3 years. After 3 years, we will reevaluate also and decide whether to continue or not. So what are the contraindications? Patients who have hypocalcemia, patients who have reduced creatinine clearance, in patients who are on alendronate, ibandronate, those who take the oral bisphosphonates, they are at high risk for esophagitis. So patients who have esophageal structure or impaired esophageal motility or unable to sit or stand for at least 60 minutes should not be given oral bisphosphonates. Usually, we ask the patients to take oral bisphosphonates, such as your alendronate, on an empty stomach 1 hour before breakfast, and they should not be lying down, for at least 1 hour. So usually what I advise your patient, if they're Catholics, every Sunday so that they will not forget. So they take the alendronate, they go to mass, and then after taking the mass, they take the drug. They eat breakfast, so that they will be they will remember how to take the drug. And lastly, of course, pregnancy. So please, my take-home message for this lecture is really don't forget to screen eligible patients for osteoporosis. No? And I almost always never forget to screen my patients for osteoporosis, or at least offer them screening. No? Um, a lot of patients forgo screening because they don't feel anything, until they get their first fracture. And I've experienced this firsthand with my mom. My mom had an osteoporotic fracture at the age of 55 years old, and I don't remember her having any risk factors except having being thin, no? And having, I think she had menopause at the age of 42. No? So she had a fall from a sitting height and developed a femoral neck fracture. And that's the only time that we discovered that she had osteoporosis. So please don't forget to screen your Lola, your Lolo, your auntie, or even your moms if they already fit the criteria for screening, to screen so that we can prevent them from developing their first fracture. Or if they've already had their first fracture, prevent another one from happening. So that's it. This is my last slide. So thank you for listening. If you have any questions, just post it in our discussion board. Bye-bye.